topics for today. Drusen, I think we'll think about adding errors on a regular basis. There are no new errors, but just wanted to do that for completeness sake. Just a reminder about NDMA. They have actually withdrawn some of metformin from some countries in the world. I think maybe the Philippines has. Clyde, I don't know if you can confirm that or not. A couple of mentions about the Orlando event and holiday sales and webinars. So to start off, when I went to the optometrist yesterday, he took a picture of my retina, and he also took an OCT, which is optical coherence tomography. It's sort of like a CT scan, but it's of the eye. And I'll show some pictures of that. I actually got him to repeat his spiel for me, and we've got a video that's coming out which shows my actual drusen. But we are backed up. It's probably going to be maybe 3 weeks, maybe longer, maybe 6 before that video comes out. Now, what is a drusen, or what is a druse, and what are drusens? They are, well, if I could get this darn thing to, when you look at them, they're dots on the back of the eye. There are a couple of types of drusen. One is an optical drusen. That's a different thing. It's not really so much related to aging. Most people just consider drusen as, quote, normal aging. That is about like IR, or insulin resistance is, quote, normal aging. And in fact, drusen are very much related to IR. They're deposits of proteins and lipids like cholesterol between some critical layers of the retina. And again, very much related to insulin resistance, pardon me. And therefore also related to aging. There's a significant linkage to inflammation. And so, as you know, there's a whole lot of people that don't understand that insulin resistance, diabetes, prediabetes is an inflammatory disease. So they're not connecting the dots, and they think, well, you know what? Maybe drusen are an immune phenomenon. As you see, this is the macular. It's got that little dark spot right there. This is where the fovea, the optic cup, the area where the optic nerve is coming into the eye. And these are drusen. Those are little deposits of cholesterol and protein. This is full-blown macular degeneration. As you see, just the macula is just eaten up with these deposits. Here is another view. And now this is the optical coherence tomography that I mentioned a few minutes ago. These little bumps right here are the drusen. And again, where you start to get into some real problems is where like one of these dips connects with the drusen and you get a total disruption of that membrane. I am not an ophthalmologist. I am still in the learning mode regarding drusen. But if you go back and look, we've already got several videos on this process. And to get back up to 30,000 feet, just to remind you, a lot of people say, well, I don't have to worry about blindness. I don't have diabetes. And when I get diabetes, I'll start worrying about my eyes. Well, that's too late. Again, by the time people get a diagnosis of type 2 diabetes, depends on the research that you see, at least a third, and I would say about a third of them already have these they already have diabetic eye damage. And I have one druse. So again, it would be hard to say that that I have damage. However, I clearly have a shot over the bow. There's no question. I did not like hearing that I've got one. And again, stay tuned for more information on Drusen. As you might remember, one of the videos, actually I've done a series of videos on folate. I also, in addition to being over 60 now and having some insulin resistance, I also have methylation challenges. And I'm not unusual, 40% of us do. And it depends, there's actually a couple of different types of SNPs that you can have, which impact methylation. And clearly, folks that have methylation problems tend to develop Drusen and other diabetic retina problems quicker. So I've always taken oh gosh, I'm having a senior moment here. I've always taken methylation. Basically what you do for that is take methylated B vitamins. Thorn is Thorn Methyl Guard is something I've recommended up until recently. And recently I was able to access a higher level of folate. Higher levels of folate, by the way, are not for everybody. Some people react negatively to those. We have started offering that. Basically, for the most part, it's Restore Me, and it's for the most part offered through ophthalmologists and neurologists' offices. We've been able to access it. We've gotten a couple of programs and offers set up, but not completely yet. We've got a couple of people that have started purchasing those. Again, the major thing to remember is, number one, be aware if you have insulin resistance. Number two, be aware if you have methylation problems. For those of you who are not aware of methylation, you're probably aware of the antioxidants. Antioxidants, especially vitamins A, C, and E, are really popular. And people talk about that. They talk about the mitochondrial theory of aging. And here's the thing. We have major advantages in terms of our metabolism over things like fungus and yeast, because they can only get like 4 to 8 energy units out of glucose. We're able to get 36, and we can do that because we oxidize. That oxidation is related to our ability to use oxygen. That's why we have red blood cells to carry that oxygen. So that oxygen allows us metabolically to break down a glucose molecule and get 4 and more times the amount of energy out of that than other biological organisms. With every advantage comes some cost, and the cost to that is that we get these it's like burning embers lying around a furnace. The mitochondria is where all this happens. Mitochondria are the furnaces of the cell. And like any other furnace, it's been used for 60 years. Sometimes you find little pieces of burning embers lying around, causing damage. Methylation, there are a huge number of processes that we use to methylate. Oxidation is removal of that hydrogen or addition of an oxygen molecule, an oxygen atom to a molecule. And I'll be through in just a minute if this is getting a little bit confusing. I wanted to get back and connect some dots to our overall metabolism. So again, if you look at mitochondria, the mitochondrial theory of aging, if you look at methylation, again, that's very much linked to this process. If you looked at quote methylators, people with problems with methylation, it's because methylation is the process that the human body uses to reduce oxidized products. Hope that wasn't too confusing. Again, tried to connect dots, but when you start doing that, you can go down some bunny holes and lose people quickly. I will leave it at that and go to errors. There are no new errors this week. I will go next to metformin and NDMA. As I mentioned, the FDA investigations of metformin continue. They have said, at least in the U.S., there's no need to stop using metformin. There's no need for docs to stop recommending metformin. And it's not metformin. A lot of people confuse it and say, well, it's metformin itself. No, metformin itself is not the problem in this space. It's NDMA, nitrosodimethylamine. And guess what? They've found nitrosodimethylamine in Zantac. They actually removed, they took Zantac off the market, I believe. They really messed with a lot of folks in terms of baby boomers, people on subscribers to this channel, because we tend to have high blood pressure along with that insulin resistance. And losartan and other ARBs had significant, were found recently to have significant significant NDMA in their products. So a lot of those got temporarily recalled. A lot of us had to switch our blood pressure medications. NDMA is very common, a common contaminant. It's even been seen in a lot of drinking waters. Excuse me, one of the things that they watch drinking water for. It's actually been involved in some poisoning incidents, which I won't get into now. We did that last week. Just a reminder, if you want to find out about sales and other activities in the channel and in our programs, go to the membership page. You go to our website and you'll see the membership page. It's fairly self-explanatory. This is an old copy. As you see, it's talking about the Heart Attack and Stroke Prevention Conference in November in Louisville. We now, that was done. It was very successful. We'll start providing a lot of content out of that event, as well as some testimonials to help you understand a little bit how those events work. We do have another event coming up in Orlando, February 28th. It's a one-day event, a little bit more affordable. There you go. We also have our courses. We have 3 courses now. Plaque, you know, if you don't know anything about this space, one of the first things that you do know and you want to find out about is, do I have plaque? Well, there's a whole story about that. In fact, I've written a book. Todd Eldridge, who does the CIMT activities, has joined me for the CIMT portions of that book. People have been asking, they're aware of it, they know it's coming out. They're saying, you know, when is it going to be available? David, for example, David Mines, who goes around and does some of the CIMT access tour, he gets some pushback from folks who are not aware of CIMT, and he's asked a couple of times for the book. I finished my piece, gosh, over 2 months ago, and you know, it's just like everything else. It's not that simple. Once we got my part done, there have been a lot of things to do to get that book out. Now, Todd and the publisher have committed to me that we think it's going to be coming out that first week in January. When it does, one of the things that we'll want to do is rank on Amazon. And a great way to rank a book on Amazon is to provide it for very little money. I mean, in the future, I don't know what we'll charge, $7, $8, $15, but we'll be very interested in getting people to buy this book, and we'll probably set up some sort of bonus where you can get it for very, very cheap that first day. That first day is critical to making the book more of a bestseller. Thank you for your interest so far. I am going to come back out of the presentation mode and deal with some questions. Okay, I see Have Faith S, sounds good. Thurston Howell III, how are things on the island, Thurston? Good morning. Bart Robinson, good morning, loud and clear, Doc. Well, good. James Camper, why was I getting a Drusen test? That's maybe a really good question. It was available. It was very inexpensive. I was able to get a picture of my retina and the OCT, optical coherence tomography that I showed here. These were just some examples off the internet. I will show you. I'm showing you mine in the video. I guess, James, what your point might be is, you know what, Brewer, I know you're not diabetic. Why are you worried about this? Or did you have any visual symptoms? No, I'm not full-blown diabetic. In fact, the vast majority of people with my level of insulin resistance have no clue. At least 90% of people with my level of insulin resistance and prediabetes have no clue that they have any problem whatsoever. As you know, I'm a career preventive medicine guy. So I screen early, I screen often compared to a lot of folks, and that was exactly what I was doing. I was screening. Thank you for the question. Thurston Howell, thanks for the, thanks, Doc. So, Healthy Chef Jimmy show. Hello, Doc. I've read some literature on metformin reducing LDL. Maybe I'm having a senior moment. Are you saying, oh, LDL particles? That very well, and the question is, do you have any thoughts? You know, it's very interesting, Healthy Chef Jimmy. When you start looking at a cholesterol test, the vast majority of people, docs included, and maybe docs especially, really don't realize that a lot of what they're looking at has more to do with insulin resistance and that prediabetes and diabetes process than it does with anything else. You know, they just think about, okay, LDL is made by the liver, and we're looking at HMG CoA, H-methyl CoA synthetase, and it's more than that. LDL is a so you have the one set of proteins, ApoB, which forms the LDL particles. How do they form the LDL particles? Well, they find the ApoB protein made by the liver finds cholesterol out in the body, in artery walls and other places in the bloodstream, connects to that cholesterol, brings it back to the liver for metabolism. HDL is made up with ApoA1. And those are some things that we look at in the particle size, particle count. One of the most obvious and important indicators regarding the insulin process, insulin and prediabetes process, is triglyceride over HDL. And again, triglyceride is one of the key components of the cholesterol panel, as well as HDL. Now, we've had multiple videos on that component. For example, Chuck Smith's video where he said, look, I lost 50 pounds and then I had a heart attack. Fat mass and BMI are critical. One of the most important, if not the most, well, you know, it's clearly not the most important. Aging is is more important. But fat mass is incredibly important to this, this process of cardiovascular inflammation. As Chuck said, I had a heart attack after losing 50 pounds, and obviously I was upset. I didn't know why. And he started watching our channel and realizing that there are clues within the cholesterol panel which show about inflammation, which is associated with insulin resistance, prediabetes. He had a triglyceride over HDL level of 5. We get worried. I get worried when it's over 1.5. He now has a level. He's lost, again, he's continued to lose weight, and his triglyceride over HDL is less than 1 now. Now, I didn't totally fishtail and reconfigure that discussion about triglyceride over HDL. You also, it's a little bit more subtle, Healthy Chef Jimmy, but you also get into things like, oh gosh, I am having so many word finding problems today. Maybe I'm, you know, it's they say it's the first thing regarding first sign of senility. Actually, I had word finding problems when I was in the 4th grade, and I was very forgetful when I was in the 4th grade. So, you know, it is what it is. The term I was looking for, I'm still, still looking for it. It's, gosh, you know what? Why don't I take another one, and I'm sure it'll come to me in just a minute. Hi, Dr. B. Whole 39. Do you have any experience with at-home cholesterol measurement devices? Similar. There's a, I think it's CholestaCheck, something like that. There's several. They've gone back and forth. People have been very interested in trying to use those for health fairs, and they're just not that accurate, at least the last time I looked. And Whole 39, it gets back to some of the previous discussion I was having, is you got to ask, how important is LDL compared to what's going on with your triglycerides, LDL, your insulin resistance patterns. So Ken Patu, is retinopathy, Drusen, reversible to any degree with dietary or pharmaceutical changes? You know, Ken Patu, that's a great question. Here's the thing. It's sort of like plaque in your artery walls. You'd much rather prevent it than reverse it. And so that's priority number 1. Prevent it before, so you don't have to reverse it. Priority 2 is stabilize it. Preventing it and stabilizing it are both very, very practical. And that's my goal here. I don't have any expectation that I'm going to get rid of my druse. I will be very happy though if I can continue to stabilize this. You know, if you look at a lot of 62-year-olds, they have far more than 1 drusen in their eyeball. So I've done a good job in terms of managing and preventing this process, and that's my major focus. It's not so much to get rid of that 1 druse, it's to prevent progression of that process. Bill Clifford, hi Doc, love your channel. Concerned about taking K2 as its possible effect on turning hard calcium deposits into the bad soft plaque. Thank you and God bless. So I have to tell you, I appreciate you bringing that up, Bill. That question, that concern continues to be an issue. You see it all over the internet. When John was working with us, he mentioned that in one of his videos, and he saw one study which indicated that they took some plaque out of some laboratory animals and did some sort of process to remove the calcium, and they felt like that decreased the strength of the plaque. Now, it's all true up until that point, and that point I'm very skeptical about. It's clearly true that soft plaque is unstable. That's what you want to get rid of. You want to harden that plaque. You want to stabilize it. You want to get it to calcified. Now, the concept and the science gets a little bit muddy when you start saying, okay, well, K2, the MK7 and MK4, MK7 more, or minoquinone Q7, pulls that plaque out of pulls that calcium out of a plaque. I don't think that's what's happening. If you start looking more deeply, what I think is going on, and there's clearly evidence on this, is that K2 is involved in activating some of the, or carboxylating some of the important enzymes that are involved in this process, like osteocalcin. Now, here's where I think the key connection is. I think osteocalcin performance has been very much linked to insulin resistance. So I clearly think there's a connection here. And I went from being a skeptic, not taking it, to taking a couple of forms of K2 supplement a day. And I do have hard plaques. I'm not worried about those hard plaques being disrupted by loss of calcium. Here's what I think is going on. K2 helps activate the osteocalcin and other enzymes that are involved in this. Then the next connection is not really understood in terms of science, but that next connection I think has to do with improving insulin resistance. And sure enough, if you look at my recent OGTT, oral glucose tolerance test, and insulin resistance tests, I've had a significant reversal. Now, is it from K2? We don't know. I'm an N of 1, and I had another significant change. For example, I started taking pioglitazone on an occasional basis. I think pioglitazone is going to be more powerful than K2 in that space. But to get back to your point, Bill, I personally, nobody knows yet. But B, this is what I do for a living, and this is what I investigate on a regular basis. And a lot of people say, okay, doc, you keep telling us about what's known and what's not known in the science. What do you think? What do you do? What I think is, again, K2 is probably more related to insulin resistance than it is actually just pulling calcium out of existing plaque. As we improve our insulin resistance, we do decrease the calcium. We reabsorb plaque. And when we reabsorb plaque, we reabsorb the calcified part as well as the non-calcified part. James Cantor, Dr. Brewer, maybe not enough sleep last night. I don't know, James. Here's what I think is going on in terms of my own word finding issues. I know that I have that when I am in a caloric deficit, and I have lost 5 pounds. I got up to 162 pounds, and I was noticing my systolic blood pressure creeping up to 130. As I was looking around for stuff that I do, I've got some patients who I've got a ton of patients. I'm going to transition over to weight loss for a second, because this is an important issue. And frankly, I think my word finding issues are more associated with my 5-pound weight loss than anything else, and I will stabilize on that. So I started a new weight loss program about a month ago, and in between, during that 5-pound weight loss, I went to New York with my family. We went out to some great restaurants. I've done a lot of celebrating, but I've still been able to maintain that weight loss. I've got some videos which I go into the details of how I did it. It's a process. Here's the big issue for me. People think that I'm just one of these genetically thin people. No, not at all. I've learned some bad habits from my family of origin. My dad was my height, and at one point over 350 pounds. I weigh 155 right now. 162 about 6 weeks ago. And if I get over 160, my blood pressure starts going up, my atrial fib starts kicking back in, and my blood sugars become more difficult to manage. One of the big issues, again, weight and weight loss is a major behavioral issue. There's science behind it. For example, the caloric theory versus the hormonal theory. I think both of those actually are true. Won't get into that unless we have questions in that space. But the big issue that I have problems with has to do with portion control. I get started eating and it's like very difficult for me to stop. So I've been on a significant caloric deficit over the past week or so. Usually that doesn't cause a problem, but word finding is my weak spot. Speaking of word finding, the word I was looking for a few minutes ago in the discussion about cholesterol was triglycerides. I won't go back to that discussion. That's a fairly complicated discussion. And it does get complicated once you start looking at LDL and remnant cholesterol, VLDL, intermediate LDL, all of those things. Those are, I think, also related very significantly to the insulin resistance process. So, James Cantor, Dr. Brewer, the picture of the eye, were pictures of your eyes? No, I didn't get a still picture. They're trying to send it, but they're having some technical problems with it. I only had one druse, one tiny druse. And so I've got mixed emotions. On the one hand, it's insignificant by itself. It's really more of a red flag that, Brewer, we know you've got this process and you need to keep an eye on it. Pardon the pun. The pictures that I showed today, James, were people that have much more significant problems. They have Drusen, plural. And one of them was actually somebody with a full-blown macular degeneration. And you see they've got these little drusen all over the place and they're very close to each other. I have one dot and it's over in this area. This is someone with many fewer drusen. And this person would not be said to have full-blown macular degeneration, but they do have, again, that process. They have drusen. As a clarification, I had only one dot. Have Faith S. Can you spell that? Pio? Oh, PIOGLITAZONE. Another way to spell it is ACTOS. Actos. It was a very popular drug back in the 20, 30 years ago. And I tend to use more of the old school drugs for insulin resistance, prediabetes. Now, Actos fell out of favor because of some challenges. Like any prescription med, it has, it's not, well, that's not true. I was going to say, like any prescription med, it's not harmless. Well, nothing is harmless. I would say this. I think Metformin is a prescription drug, and it is relatively harmless. It should be over the counter, but that's a different issue. Actos was very popular. It was found to have some link to bladder cancer, some link to weight gain, and that scared a lot of people. And so it fell out of favor. But I think Actos is a very, very good drug for people like myself who are continuing to age, continuing to have more and more challenge with insulin resistance. I don't use Actos like a lot of people have. I tend to use it more sparingly. I'll use it like a dose or two per week. And there's not a lot of science on the impact that it has using it sparingly like that. But like I said, as an N of 1, I've seen significant improvement in my OGTT and IR numbers. And the only two things I can think that would be coming from would be the vitamin K2 and or the PIO. So James, oh no, you already covered that. Oh, perhaps you can do a video on how to avoid eating at night. Actually, that's a really good video. As one of the things that I'm covering more topics regarding weight loss, and it's not that I've never done done them before. I've just been more focused on science. As you get into weight loss and managing a healthy weight, behavior becomes a big issue. And I covered one on the potato mono diet. Penn Jillette, if you've heard of Penn and Teller, it's a couple of magicians who are very popular in Vegas and some other places. Penn Jillette lost 100 pounds, and he did it by eating a potato diet. And he was very clear. He said, you know what? A lot of people think this is a really weird diet, and maybe it is, but I only eat when I'm hungry with potatoes. You know, you can only eat so many potatoes. However, when I'm eating burgers, when I'm eating other things, it's really hard for me to stop. And although a potato mono diet is certainly not my go-to, it clearly does manage some of that thing that we need to recognize, and that is there's a major behavioral component to managing a healthy weight. In our family, I never really had evening snacks, midnight snacks until I got married, and Janice has a major habit of what she calls midnight snacks. Those are not good for you. In fact, if you're going to close your eating window, it's actually, the science would indicate you're better off eating breakfast and lunch and skipping dinner. Most people call they call it intermittent fasting. And when I have a patient that says, well, I'm doing intermittent fasting, I assume, just because of how many times I've heard it, I assume that they're basically skipping breakfast. You'd be far better off eating breakfast and skipping dinner. But when I close my eating window, which is most of the time, I'm skipping breakfast as well. It's socially much more difficult to skip dinner than breakfast. So yeah, thanks for the suggestion. Again, eating's a very behavioral thing. Thurston Howell III, Doc, thoughts on Repatha class drugs vis-a-vis plaque removal? I'm not familiar with significant science and evidence around plaque removal specifically with Repatha. Basically, what Thurston's referring to is the PCSK9 inhibitors. And those were developed for people with, for example, people with familial hypercholesterolemia. They're developed, it was an interesting process how those medications were actually developed pharmaceutically. They sort of went backwards from the way that they usually go in terms of developing medications. The way they usually go is they inventory chemicals that they find in plants in the Amazon and other places like that, and then they start looking at impacts in the metabolism that those chemicals have. And then they find an impact and they say, okay, where can we apply this? They did it the opposite way with the PCSK9s. They looked at people who had low LDL. And they found, I think one of them was a cheerleader in Texas who had a very low LDL, and they did a genetic analysis, a genome study. And then they start finding the genomes that create that. Then they go back and analyze the genome and create the medication from that perspective. So it's just an interesting component of science and genetics. Now, as you might imagine, the PCSK9s came out of the blocks, gosh, what? $17,000, $20,000 a year, very, very expensive. There've been some decreases in costs recently, but you got to go back and ask the question. So many times when I see Repatha and the PCSK9 inhibitors being given, they're being given under that old standard assumption that everything is LDL, and they're focusing on LDL. Meanwhile, the robbers, the bandits, are continuing to operate in plain sight, and they're not looking at them. Meanwhile, the patient has significant insulin resistance. So one of the things that I find I get a lot of patients that come to me that have FH, familial hypercholesterolemia. They have, there have been a lot of discussions about Repatha and some of the PCSK9 inhibitors. And we focus first on managing insulin resistance. It gets back to that first question about maybe the impact of insulin resistance and diabetes on LDL. As we start getting insulin resistance in control, a lot of the cholesterol values fall back into line. Now, I will say this, speaking of things not being that simple, I mentioned remnant cholesterol. I didn't mention lean mass hyperresponders. Some people actually get a significant increase in LDL once they go on like a keto diet. I won't go into that right now. You'll see a lot of that with Dave. I can't remember his last name, but you can Google lean mass hyperresponders. I've got several patients that are like that. Actually, I had a patient recently agree to provide us a video on it. In fact, Clyde, assuming you're listening, we had two very good videos in this space. They were on the Zoom meeting recordings. We need to make sure that we're using those, that we've got those, that we provide that information, because those were great videos on lean mass hyperresponders and FH, familial hypercholesterolemia. So, Hull 39, sorry if I missed it. Could you please tell us which K2 supplement and how much you take per day? Okay, so I take Sports Research, I think is the name of it. And I believe you got to watch it. What I'm trying to do is take the one that has 100 micrograms of K2. It's MQ7, menaquinone 7. I also take, let me see if I can find that for this group, natto powder. I put natto powder in my morning coffee. Let me see if I'm going to be able to find that. Amazon natto powder.
Doc, if you're trying to share that, kindly change your sharing settings. Okay.
Yep, got it. Thank you. Hopefully this will start bringing that up. Is it showing it now?
Yep.
And let me see my orders. Oh gosh, it's going to take me through. Let me see. Hopefully we can get there, but it's a natto powder. So what I'm doing is getting two different sources of K2. K2, by the way, is fermented soybeans. It tastes really, really bad. I've been putting it in my coffee for about 3 months, and I'm just now getting used to it. I used to work with for Toyota and made a few trips to Japan. This is what I put, by the way, in my coffee. So as you can see, it's all in Japanese. I cannot read kanji or hiragana, katakana, which that's it looks like we've got maybe all three of there. And it says 300 grams. So I really don't know how much K2 specifically I'm getting with it, but I do supplement as well through the supplement that I mentioned a few minutes ago. I may be able to find that real quick for you. I've actually found you need to watch the supplementation that you do, because sometimes you'll get it with D3. Sometimes you'll get it without D3, and I've done that both ways. This is, as you can see, Sports research, plant-based K2 plus D3, 2-in-1 support. 100 micrograms of K2 as MK7 and 5,000 international units of D3. Here's the problem with that. I mean, the advantage is that you can get your D3 rather than taking a separate pill. 5,000 international units is a good amount for D3. However, the standard supplement amount for K2 is 100 micrograms. If you go back and look, I have found one study which showed an improvement in insulin resistance with supplementation from using K2. That was like 400 micrograms. So I think the 100 micrograms is too little. What I would like to do, and I'm talking with some guys about developing this, it's going to be a long time before that happens. I'd love to have a K2 D3 just like this, except have more like 300 micrograms of K2 and 500 international units of D3. Great question. Thank you so much for bringing it up. Have Faith S. I make natto with black beans. Very, very good. A lot of people like it. Obviously, the Japanese like it. They eat it because they like it, not so much because it has K2. And yes, Feldman was the last name. Martin Bredehoff. You may have been thinking of Dave Feldman. Another good video by Nadir Ali. Nadir Ali's got a good video as well. I'm not 100% there with Nadir Ali. He tends to say I think he's a cardiologist, and he's all into you want to have higher LDL values. Higher LDL values are healthy. Yes, I don't think that higher LDL values are as dangerous as most docs do, and in fact, I do prescribe statins, but less than half the time that you see in standard medicine. And when I prescribe statins, it's not because of LDL. It's because of known documented plaque. Nadir Ali, what I've heard, would say you want to push higher LDL values. I don't 100% agree with that. And I think he is, I think he's got some weak spots in his presentation, and I think he's ignoring some science out there. Ken Patu, the lean mass hyperresponder argument, the LDL doesn't matter, sounds a lot like wishful thinking to me. That's Korean, by the way. I think some of that, there's part of me that agrees with that, Ken Patu. Pinchas Guzman, do you think that the cholesterol increase during a ketogenic process is because of soft plaque breaking up from glycosylation? Actually, I don't. I do think that that David Feldman's mechanism for it, in that I think David Feldman's mechanism about increasing number of empty boats out there is actually a more accurate description of the mechanism. Susie Penguin, less expensive than Mercola's D3 with K2. Oh, well, thank you for letting us know that. Very good. Healthy Chef Jimmy Show. My remnant went from 84 to 134 in 54 days. Chef Jimmy, I would suggest that maybe you want to check that number. The remnant that we're talking about is total cholesterol minus HDL minus LDL. And that's where we're looking at things like VLDL and intermittent density lipoproteins. So those are usually in the areas of like 12 to 20. You know, when you get closer to 20, it's showing you've got much more VLDL. The VLDL and ILDL, intermittent intermittent density lipoprotein, those are much more atherogenic, much more plaque causing. And that's what we're looking for when we get remnant cholesterol. Total cholesterol was 119, now 158. Should I be concerned, or was it the eggs? Other than that, nothing else has changed. Healthy Chef Jimmy, here's what I would do. I would, first of all, make sure that my insulin and carbohydrate metabolism are correct, I would get an inflammation panel, and I would get an OGTT, and I would get an insulin response. Now, if you go back and you look at things that we have available, we have that in our webinar. We call it a webinar. It's a discussion of results in that area. That's the first thing to look at, and I think that's the most important thing to look at. And again, we get so many people fiddling while Rome burns. We continue to focus on small variations in cholesterol values. Meanwhile, our arteries are getting eaten up with problems with glucose metabolism. So we're getting on. I was trying to keep these to closer to half an hour. I appreciate the interest. Clyde, what we can do is just cut some of the last components off to make this more interesting for folks in terms of reviews later. One last item, and then we'll close it out. Bill Clifford, in recent YouTube with David Sinclair, he quoted study in which low daily intervals of daily eating habits was more important than what was eaten. Hard to believe. He also takes metformin as supplements. Not sure if you're referring to David Sinclair. Yes, David Sinclair has taken metformin as an anti-aging drug. It does more than just impact your blood sugar. It impacts AMPK and some other biological indicators in the body. It also changes the gut biome from a gut biome that tends to drive insulin resistance, prediabetes, to a healthy gut biome. So, no trash in heaven. Dr. Brewer's your wife changed her eating habit at night. That's a struggle. Sometimes I have to say, okay, you know what? That's her behavior. I've got my own behavior. Thank you very much for your interest, folks. Talk to you again soon.